Angela, it's Simone. Are you still short of lines? Because I can get off and join somebody else.
I think we're okay. I think Larry managed the attendees accordingly. We have a wait list for today, but yeah, I think we're okay. Thank you, though, Simone, for the offer.
Okay.
So I have, for folks on the line, just to know, for disclosure, we are recording this session with the hopes that we'll be able to post it for those that aren't able to attend and listen in today. But thank you very much for taking your time to spend with us and Dr. Phillips to learn a little bit more about the new 2018 clinical practice guidelines that have been released nationally through Diabetes Canada. They came out early April, second week of April, I believe. And so this is our first effort, anyways, to provide some information around those new clinical practice guidelines, some reinforcement about previous best practices and what's been highlighted, and highlights and overview of any new recommendation or changes that may be forthcoming. So I'll pass it now to our speaker, Dr. Richard Phillips, who's an adult endocrinologist working out of Kelowna, who joined our health authority in July, at which time he also signed on as our regional diabetes medical lead. So with that, I will start the presentation. We will allow for question and answer at the end. So please, as I mentioned at the front end, if you don't mind *6 to mute your line until then, and then #6 to open it up. And Dr. Phillips, I'll load the presentation and you can pass it over to you.
Right. Okay. Well, thanks very much, and welcome everybody. So the topic of today, diabetes in older people. If you look at the author for the chapter, Dr. Grady Meneely, he's been involved in this area for as long as I've known him. I've been an endocrinologist for 20 years, and he's done a lot of research in this area. He's currently the head of medicine at UBC, actually, but a very well-known geriatrician in this area. The other plug will be David Miller, is an endocrinologist in Victoria, and he was my practice partner for most of those 20 years in Victoria. So it was interesting that he had a rule of thumb many years ago that isn't in the guidelines, but is somewhat alluded to. He used to say that one's target A1c should be your age divided by 10, and he only said that somewhat jokingly. What he meant was that the theme was that as people get older and they accumulate comorbidities and frailty, that the benefits of tight glycemic control are potentially outweighed by the downsides. So that's an old anecdote from before. So next slide, and next is again. So key changes. It doesn't look like there's been a heck of a lot of change since the previous guidelines. They say that there's new information on screening with fasting blood sugar and A1c, and de-prescribing in older folks. So when you actually read through the chapter, actually when we go through the slides, they don't mention anything about screening and so on. So I'll just talk about that now. So what they do mention is that the relevance or the accuracy of hemoglobin A1c in reflecting the true average glucose, that relationship between glucose values and A1c, that relationship does become more skewed as you get older. We know that there are some people that have hemoglobin A1cs that don't reflect their average glucose if they have underlying hemoglobinopathies. What they mention in the guidelines is that as people get older, the A1c goes up, and the relationship between average glucose and A1c becomes less of a tight relationship. So they're saying that if you're screening for diabetes in older individuals, that they're recommending not just relying on the hemoglobin A1c, but relying on some sort of glucose measure as well. That's why they're saying do both the fasting plasma glucose and an A1c for the purposes of screening. They also mentioned that the value of screening for diabetes over the age of 80 is dubious, and we probably shouldn't be screening for diabetes after the age of 80. But in younger, older individuals, if you know what I'm saying, if you're going to screen, then do both fasting plasma glucose and A1c. As far as deprescribing, that's sort of the popular thing to do these days to address the issue of polypharmacy. So I think it's a big issue. As people get older, they accumulate an increasingly long list of medications, and it's relevant in older people with diabetes in the sense that generally we're looking for less strict glycemic controls as people get older and accumulate comorbidities. And as they get older and they eat less and potentially lose lean body mass and gain more fat mass, the risk for hypoglycemia increases on certain medications. So deprescribing is sort of the in thing now, and they're recommending we do that. Next slide, please. So this is a whole bunch of things all in one. So I guess something that I do informally but don't do in a formal sense is come up with a hemoglobin A1c target for the patient in front of me based on my sort of general assessment of their frailty, their accumulated comorbidities, their estimated life expectancy, because that will determine how aggressive you need to be with the blood sugars, and give me an assessment of what their risk is for hypoglycemia. So I think probably the major aspect of this whole chapter is assessing the frailty score of people and coming up with an A1c target based on that determination. So we have to individualize the glycemic targets. So clearly an A1c of less than 7% in people in long-term care is would not be an appropriate thing in people on sulfonylureas or insulin. You would have to ease off the targets. Of course, if one's just on metformin and has an A1c in long-term care of 7%, that's fine because the metformin isn't going to cause hypoglycemia as monotherapy. So you have to sort of take in the whole picture. Certainly, we need to avoid inducing hypoglycemia in patients with cognitive impairment. It's a bit of a vicious circle here. There's evidence that severe hypoglycemia promotes cognitive decline, and those patients who have cognitive impairment are also more likely to become hypoglycemic. So one feeds the other. So we have to be cautious with certain oral hypoglycemic agents in the elderly, sulfonylureas, especially glyburide, causing severe hypoglycemia. I generally tend not to use glyburide hardly ever, but especially in people over the age of 70 with any elements of renal insufficiency, glyburide's really a no-no. And we'll discuss later that if you need to use a sulfonylurea, that glycoside would be a better choice. Thiazolidinediones can be used, but rarely, due to the fact that they cause fluid retention, and especially in women can promote osteoporotic fractures. One of the themes of the guidelines is that if you've got an older person with any elements of renal insufficiency, that probably the drug of first choice for type 2 diabetes is a DPP-4 inhibitor. So the sitagliptin, saxagliptin, linagliptin drugs, due to their safety and the fact that many of the studies that were done with these agents had a large proportion of elderly people in those randomized clinical trials. So there's good evidence for their safety in that age group. And the other thing is that if you're going to be using insulin, that the preferred basal insulin would be the insulin analogs like Lantus or Levemir or some of the newer ones, as opposed to NPH or Premix 3070, again, based on reducing risk of hypoglycemia. One of the other things that they stress, in no great detail, but they do provide some literature to suggest that in long-term care, that we should be providing people with regular diets as opposed to specific diabetic diets due to the fact that undernutrition is quite common in diabetics and long-term care. So, and that switching people to regular diets from diabetic diets hasn't been shown in these small studies to cause any deterioration in glycemic control anyway. So a lot on that slide. Let's just see what the next one shows. Now, I'm not a geriatrician, so I'm not an expert in frailty by any means, but this is the definition provided by the guidelines, denoting a multidimensional syndrome giving rise to increased vulnerability. So frailty is what we're looking for. Next slide. Let's just keep her going all the way. One more, I think. There we go. So here's the A1c target. So clearly there are some patients over the age of 70 who are functionally independent. They're doing well. They have minimal comorbidities. They've got a life expectancy of 10 years plus. Thus, the glycemic targets for these folks is the same as everybody else, generally speaking 7% or less if you can achieve that safely. As you move along the spectrum, become functionally dependent, you're accumulating comorbidities, becoming increasingly frail, then the A1c target moves up to between 7 and 8%. And once you add in their cognitive impairment and limited life expectancy, long-term care people, then the A1c goes up to 8.5% as being acceptable. Once you get above 8.5%, the concern is that these folks will develop symptomatic hyperglycemia, and that will complicate their care by increasing polyuria, polydipsia, volume depletion, falls, infections, etc. So 8.5% was felt to be a reasonable target to keep people out of that scenario. Once you're in an end-of-life situation, then we're generally not measuring A1Cs anymore. If they have diabetes, you're just trying to avoid symptomatic hyperglycemia and strictly avoiding hypoglycemia. It's interesting that when people have actually looked at the level of glycemic control in long-term care facilities, there's a significant proportion of people that have A1Cs of 7% or less while on medications that could potentially cause hypoglycemia, such as sulfonylureas and insulin. And I think that one of the messages of the guidelines is that if you are in that high-risk group, high frailty score on medications that can cause hypoglycemia, like sulf or insulin, that A1C of less than 7% needs to be relaxed, needs to go up above 7.5% to avoid the hypoglycemia, because these people aren't going to necessarily tell you when they're hypoglycemic. We know that the elderly have reduced counter-regulatory responses hormonally to hypoglycemia. They are less aware cognitively of when hypoglycemia occurs, and many of them will be in a less of a position to actually act on their symptoms if they do get them. So they're really sitting ducks for hypoglycemia. So people have actually slapped on CGM, continuous glucose monitors in these folks to look at how often they develop asymptomatic hypoglycemia, and it's much more common than any of us would have thought. So it is a silent epidemic of sorts. So relaxing glycemic controls in people on sulfonylureas and insulin is appropriate. Next. This pretty much says the same thing, just focusing on the clinical frailty index. The guidelines do provide a means of figuring out the frailty index. They have a figure 1, based on a report by Morehouse that is really easy to understand. So, for example, functionally dependent frailty index of 4 or 5. Number 4 would be considered vulnerable. While not dependent on others for daily help, often symptoms limit activities, a common complaint is being slowed up and or being tired during the day. Angela, I think I got a frailty index of 4. Number 5 would be mildly frail. These people often have more evident slowing, need help in high order IADLs. Typically, mild frailty progressively impairs shopping and walking outside alone, meal preparation, and housework. So for those folks, we are, easing off on the A1c targets. Okay, and this is simply comparing the Diabetes Canada guidelines to the ADA and to the International Diabetes Federation targets. Fairly similar as far as the glucose is concerned. As far as blood pressure is concerned, the Diabetes Canada is still suggesting blood pressures of less than 130/80 for most folks. But when you get into those people with limited life expectancy, then you need to individualize the targets and generally back off on them. LDL cholesterol, still recommending less than 2 for all comers. Once you get, strictly speaking, when you look at the literature on statins in the elderly, there's no good evidence that adding a statin after the age of 75 is beneficial. If someone's been on a statin for years and has tolerated it, and they become 75 and beyond, and they've done well on their statin, then it's perfectly reasonable to continue it if they've got underlying evidence for cardiovascular disease. If it's purely on the basis of primary prevention and they've got multiple other comorbidities, then in the interests of de-prescribing, then in individual cases you may be stopping the statin. So, basically it's using common sense. Next slide. I don't want to talk about the Golden study because I don't know anything about it, and they don't talk about it in the guidelines. So let's move along. Basically, I think the thing they're trying to say is that older people are less able to perceive hypoglycemia, and we've talked about that already. These are just regular CDA guidelines. They're not really specific to this chapter, so I think we can blast through it, Angela, actually. So a few all the way. Next one again. So let's talk a little bit about, can we get to the next one? Next one. So we could talk a little bit about renal function and various agents. So I think one of the themes of the guidelines is if people who are older and with renal insufficiency and multiple comorbidities, if they need an oral hypoglycemic agent for diabetes, if they don't have any contraindications, the recommendations are still to start with metformin. If the GFR is less than 60, then you won't be wanting to go to full dose metformin. So 4 to 5 pills a day in an older person with a GFR less than 60 wouldn't necessarily be the right thing to do, but certainly 500 milligrams BID would be safe to do so, and getting rid of the metformin once the GFR is less than 30. If you need to add something to the metformin, a DPP-4 is considered safe. It won't cause hypoglycemia and can be used in people with renal impairment. So I think that's would be generally the drug of second choice for older folks. They do say that consideration could be given to one of the newer agents in older people over the age of 70 who have established cardiovascular disease, MI, stroke, peripheral vascular disease. In that situation, you could consider an SGLT2 inhibitor for the purposes of not only lowering blood sugar and not causing hypoglycemia, but for reducing cardiovascular mortality and reducing hospitalizations for heart failure. The caution in the elderly with these drugs is that by acting in a diuretic and natriuretic fashion, these folks are prone to volume depletion and potentially falls. And so that's why in the clinical trials with the SGLT2 inhibitors, there was an increase in osteoporotic fractures with these drugs, and it was felt to be most likely related to an increase in falls induced by volume depletion. So you have to be cautious with these agents, but they are a possibility. Of course, they're not covered by pharmacare, and so if the patient is on metformin, needs something in addition to lower the sugars further, but they don't have any extended coverage and they're not independently wealthy, they may not be able to afford a DPP-4 inhibitor or an SGLT2 inhibitor, in which case cautious use of low-dose gliclazide or gliclazide MR would be a reasonable thing, avoiding glyburide like the plague in this group. So we've touched on the renal function a bit. Let's move to the next one. So this was an interesting one. I haven't done this before, but I think I'll probably start doing it. In hospital, when we're sending older people home and they're new to insulin, and you're wondering whether they'd be able to handle it if they are going to be responsible for giving themselves their own insulin. This particular recommendation was interesting. So it was using the clock drawing test to predict as to whether they're going to have difficulty from a cognitive point of view handling insulin therapy. So I thought that was a potentially useful tool in the toolbox. Long-term care, undernutrition is a problem, so put them on a regular diet. The other issue is frequent silent hypoglycemia in these folks if they're on sulfonylureas and insulin. So if that's the case, back off on that. The other interesting point I should say about that is that even if the A1C, if somebody is on sulfonylureas and or insulin in the elderly long-term care situation, and you relax their A1C towards the 8 or 8.5%, that doesn't preclude them from getting hypoglycemia if they're on those agents, because we know that the oral intake, the caloric intake, isn't always consistent with these people. So just because the A1C is higher doesn't guarantee that they're not going to go hypoglycemic. So they do mention a pilot study in the index of the guidelines that was sort of deprescribing multiple day insulin regimens and giving a trial of therapy with Lantus insulin as monotherapy. Now, in my experience, that frequently doesn't work, but it's certainly worth a trial. If somebody's on premix insulin twice a day, or even basal bolus insulin 4 shots a day, and they've got multiple comorbidities and cognitive impairment, it would be reasonable to give a trial of once-a-day Lantus in the morning, along with 1 or 2 oral hypoglycemic agents that don't induce hypoglycemia, to see whether you can get by with that regimen, and in doing so, reduce the risk of hypoglycemia. So it's something to think about. Might be worth a try. Next, so I think the recommendations at the end of this is basically reiterating all we've talked about. Perhaps this might be a good time to open it up. Angela, what do you think?
Sure, sounds good. So thank you, Dr. Phillips. So we do have until 1. For anyone that wants to ask a question, again, if you've got your line muted, just hashtag 6 to unmute yourself. And if you're not asking a question, please do ensure your lines are muted. I think we've got some background feedback right now. So go ahead and feel free to unmute and ask the question if you'd like.
Hi, Dr. Phillips. It's Catherine in Cranbrook. I just had a question in regards to the slide that was the anti-hyperglycemic agents and the renal function. That one's different than the 2016 one. Is that the updated one for everybody, or is that specifically adapted for renal, or for elderly, sorry?
This would be for everybody.
Okay.
Thank you. And the it's interesting. Let's just make sure that it's interesting that if you look at the most of the way down the table on the SGLT2 inhibitors, specifically empagliflozin. So green it's good to initiate if their GFR is over 60. Generally, the original product monograph says don't initiate if the GFR is less than 60, but you can continue it less than 60, but stop it at 45. They've actually changed the product monograph such that with empagliflozin, you can continue that drug down to a GFR of 30, which is interesting, basically due to the fact that the EMPA-REG study showed cardiovascular benefit and renal protection down to a GFR of 30. Of course, you're not going to get much bang for your buck on lowering your glucose if the GFR is less than 45, but due to those putative benefits on the heart and the kidney, they've opened up the renal indication down to a GFR of 30. So, you know, things are changing all the time, and slides are always out of date by the time you make them.
Thank you. Further questions, anyone?
I just have a little question. It's Williams Lake. More of just looking for a recommendation of a 68-year-old gal with uncontrolled diabetes, lives quite a ways out of the town of Williams Lake, renal cell CA, had a nephrectomy, stage 3 kidney disease. She has a GFR of 47, and her A1c was 17.7, and no fasting. And they're looking at insulin, and there is some cognitive impairment and adamant on insulin. Is that something that's appropriate if she's got some cognitive impairment with the other things going on?
Right. Does she live? Is there somebody else that could give the insulin, or does she live with anybody?
Not really. It's not. I mean, the home situation. They're not. There's people in and out of the home. There'd be no complete compliance.
Right. That's a really tough one. I mean, if your A1C is 17%, I mean that spells insulin. I'm afraid. But presumably she doesn't have extended medical drug plan, Blue Cross, all that sort of stuff. Be dependent on would be dependent on pharmacare.
First Nations Health Authority, or First Nations.
Okay, right. So that's somewhat helpful. I mean, for somebody like that, I would probably. With the First Nations coverage is a bit better. I would probably do, if somebody else could administer the insulin once a day, and it could be any time in the morning, whether it be, you know, somewhere between breakfast and lunch, you know, once a day Lantus or Basaglar or whatever they have covered, along with something like linagliptin during the day, that would certainly take the edge off things. And then if that doesn't get the A1C below 10, then you could add a teeny tiny dose of glycoside MR, 30 milligrams once a day in the morning. But I think what you're looking for is a basal insulin and one or two, you know, reasonably safe oral agents to try to avoid her from being symptomatically hyperglycemic, which is just going to, you know, complicate her management otherwise. I mean, if she's got blood sugar is consistently over 14, she's going to get volume depleted, and that's going to lead to pre-renal azotemia and worsen her kidney function, and, you know, down she goes. So I think that would potentially get her down below 14 if you did that.
Perfect. Thank you.
Thank you. Other questions? Again, #6 to unmute yourself.
Hi, Dr. Phillips. I have a question. I'm wondering, the renal limitation, is that usually related to, like, the lack of the kidney's ability to appropriately clear the med or, like, alter the half-life, or is it usually related to the potential for further renal damage? Right.
It's different for all of these drugs, actually, and some of the times it's due to the fact that no one's ever studied it, so they don't know. So, for example, if you go to the GLP-1 receptor agonists, the exenatide is read below 30 due to the fact that that particular GLP-1 receptor agonist is cleared by the kidneys, whereas with liraglutide, it's only read down below 15. The drug isn't cleared by the kidney at all, and the only concern there is that if you initiate the drug with a GFR less than 15, and if they develop nausea and vomiting, they become, you know, volume depleted, and that might tip them over into needing dialysis. So different reasons for the color codes. Some of the drugs, like the DPP-4 inhibitors, if you look at linagliptin, you're smooth sailing all the way down to a GFR of 15, they say use, quote, with caution below 15. I mean, many of us use it below 15 without any difficulties. So, sometimes it's going to be, actually, with very few of these drugs, is it going to be that the drug itself damages kidney function. Even with metformin, many patients say, well, I stopped the metformin because it was damaging my kidneys. Well, metformin doesn't damage the kidney, of course. It's only, it potentially accumulates in the setting of renal impairment and can lead to lactic acidosis. So in most cases, it's not damage to the kidneys itself. It's either lack of study, nobody knows, or drug is cleared by the kidney and can accumulate, or lack of efficacy below a certain level, these sort of things. So it's different for every class.
Further questions, anyone?
So in the elderly, it's Simone from Cranbrook. In the elderly, if they need a rapid-acting insulin, do you just try to hook up the Lantus with whatever rapid-acting insulin you choose in the morning, just so they have the same shot time? Have you found that beneficial?
So you're using Humalog or NovoRapid for these folks? Is that what you're saying? So or
a Pedra, or whatever.
Right. Because when they need a rapid-acting analog, if you can get away with the old basal plus routine, that's once a day rapid-acting insulin, that would be preferable to a full-on basal bolus. And I think most people's main meal would be at dinner time. So strictly speaking, you could consider a Lantus and a Humalog or whatever rapid-acting analog you choose as a basal plus regimen once a day pre-dinner. I mean, that's not that's not unreasonable if they're able to do it themselves. Clearly, the the community nurses generally aren't in there in the late afternoon pre-dinner. Is that what you're referring to, sort of?
Yeah. I was referring to when's the best time to give that rapid acting at what meal. So you're right, the basal plus one. So they just do not seem to tolerate breakfast well, or maybe it's what they're eating. Their glycemia usually goes up fairly high. Yeah. But I'm just wondering, I'm just curious as to.
Yeah. So yeah, if you're going to use the basal plus, then you would do it prior to the main meal. If you're just doing the basal by itself with one or two oral agents, then arguably giving the Lantus in the morning may be less likely to cause nocturnal hypoglycemia than giving it in the evening. So that's why I would say in the morning.
Okay. And I'm just moving through the recommendations as the conversation is being had, but are there any further questions before we adjourn for today?
Hi, we have another one. Dr. Phillips, with Tresiba, the ultra-long-acting insulin, when the rep was here telling us a little bit about it, the conversation of every other day dosing or even a Monday, Wednesday, Friday dosing came up. Have you seen that? Are you using that at all, or are you strictly using that once a day? Yeah,
I haven't done that ever. And I would be surprised if the rep was recommending that, because it's certainly not part of the.
No, I should. Certainly, after she left, we were just hypothesizing, like at the last hours, or you had like the frail elderly, someone that lives alone, for the sake of family burden. If their daughter's coming in Monday, Wednesday, Friday, and giving her some insulin, is that better? If it wasn't the rep saying that. My bad.
Yeah. No, I mean that's an interesting point. I mean the studies that have been done with adjusting the timing of the Tresiba, I mean it's basically looking at one day you take it in the morning, the next day you take it at night, and then the next day you would take it in the morning. So you would sort of varying the dose 8 hours apart versus 16, more than 24 hours apart, that sort of thing. And they found that, if you varied the time from day to day, that it didn't make any difference. I don't think we have any data on skipping the days. It's not a bad idea, though. I mean, the half-life is in excess of 40 hours. It would certainly be better than nothing, and it might be worth a try. No, it's a good idea. Of course, when you take it daily, I mean, you do reach a steady state after daily administration. Would you maintain steady state if you did it every other day? I don't know the answer to that. It's not a bad idea. If that's the only option you have, then it's not bad.
Great. Okay, well, unless there's any other questions in the queue, Dr. Phillips, any closing remarks?
Well, if anybody's really interested in this, there's the latest edition of Diabetologia that has a review on diabetes in the older patient. Heterogeneity requires individualization of therapeutic strategies. Just hot off the press. So if you're interested, it says much of the same thing. I think what clinicians need to do better is to set set targets for A1C based on some assessment of frailty and risk for hypoglycemia. And what worked in one decade may be inappropriate as the patient gets older, and the whole concept of deprescribing, I think, is a useful concept. So frailty and deprescribing, how's that? That's the message.
Great. Well, thank you so much for taking the time, Dr. Phillips, and for all of you that participated today. So we have hopefully successfully recorded the sessions, and we'll be sharing them out to all of you as attendees should you want to revisit any of the information, as well as posting online. So if you are curious about the guidelines, the website is there, guidelines.diabetes.ca, and of course can be accessed as well within Interior Health on our InsideNet Clinical Care Resources page. We have a link to the guidelines as well as any relevant interior health practice standards on the Diabetes InsideNet Clinical Care Resources page. So, and that is likely to be the location where these are posted as recordings as well. So thank you all for your time. Thank you, Dr. Phillips, and enjoy the rest of your day.
Thank you.
Thank you.
Bye.